Hi, good evening, everyone. I am about to be going live with Dr. Smikle from Laurel Fertility Care based in San Francisco. And he will be explaining all about OHSS. So, what to look for, why it happens, what does it mean, all of the above. We'd love your questions. If anyone wants to know anything, then we have Dr. Smikle on hand, who is the medical director of Laurel Fertility Care based in San Francisco. So lovely to see those of you who are joining today. Hope you're doing all right, and he will be joining any second. We're talking about OHSS. What does it mean? Who may suffer from it? Should you be worried about it? All of the above. So let's get him to join now and we can take it from there. Hi, everyone. Nice to see you. Hello, Dr. Smikle. How are you?
I'm doing okay. How are you doing?
I've got a bit of a cough, so apologies if I have a coughing fit.
That is actually okay. Well, we understand that there's a lot that's actually going on, so I'm glad you're able to continue to do this. So hydration is great. So I see that.
So please reintroduce yourself to anyone who doesn't know of you, and a little bit about Laurel Fertility Care. And then we're going to talk about OHSS today.
Okay. So I'm Colin Smikle. I'm the medical director of Laurel Fertility Care. We have offices here in San Francisco and the Bay Area, and also servicing patients from around the world, and been managing and doing this for close to 17 or 18 years now.
Amazing. Amazing. You've helped a lot of people, and we've met now in person, which is wonderful. So first of all, what is the definition of OHSS? What is it?
So OHSS, Ovarian Hyperstimulation Syndrome, the definition relates to the fact that, sometimes spontaneously, that's rare, but on occasion you'll end up having the ovaries getting a lot bigger. The surface of the ovary will leak fluid, and that leaks into the abdomen, and then therefore that causes bloating, discomfort, and may actually have other symptoms as well. It comes about after most times after some type of ovarian hyperstimulation. Rarely you can actually see it with either clomiphene or letrozole use, but those are usually pretty uncommon. The reason for that is just that with clomiphene or with letrozole, typically the ovary will you'll ovulate to 2, maybe 3 or 4 eggs, but not usually more than that. And hyperstimulation comes when typically you're ovulating, say, 10, 15, or 20 eggs on the low end. There are individuals who may end up having a lot more eggs, so therefore you often see it more after more aggressive hyperstimulation, ovarian hyperstimulation, typically for an IVF cycle.
Okay.
So that's what it looks like.
Mm-hmm. And when you say more aggressive stimulation, what kind of patients may need more drugs?
It's not necessarily more drugs as much as there are some patients who are more predisposed to having ovarian hyperstimulation. Patients with polycystic ovary syndrome, those are women who, especially if they've never been stimulated before and there's not a history, you'll end up going through and you're uncertain of the dose of medicines that are required for stimulating the ovaries. They respond really pretty quickly, and then they'll actually grow really, a lot more robustly as well. And typically, even though we may be monitoring really closely, it's one of the things that it's harder to control once it's already started. So patients who are thin, patients with polycystic ovary syndrome, patients with a high AMH, those are the typical patients you'll see and will monitor for ovarian hyperstimulation.
Mm-hmm. I remember when having stimulation, you're waiting, aren't you, for a certain amount of eggs to reach a certain size before retrieval.
Right.
And you want the ones that aren't, or as a patient, you feel like you want the ones that are smaller to grow in size by the date, as you're getting closer to the retrieval date. But obviously, you're monitoring the big ones, aren't you? Because you don't want them to get too big. And could you tell us a bit more about that and how that could then lead to OHSS?
Right. So what happens is just that most patients will think about it as that they want as many eggs as you can get. And so in a typical IVF cycle, the goal is to get, say, between 15 and 20 eggs. But so you'll start out with a dose of medicine aiming for that goal. But then, let's say someone hyper responds, you'll, instead of getting 20, you have 50. Even though you're seeing early, you many times try to moderate or reduce the doses of medicines to not stimulate the ovaries as aggressively. The unfortunate thing is that if you do that too earnestly, then you'll end up having, as you mentioned, some of them grow, but also some of the eggs may die, and therefore that's always a balance. And so, the key thing is that if they grow and they grow too quickly, then what happens is just that the other ones, the smaller ones will continue, the larger ones will get too big, and then the eggs will die or become what we call atretic. The key thing, though, is just that balance always plays a role when you're walking that fine line in terms of getting a certain number of mature eggs and continuing to feed those eggs as they develop. Because one way of trying to try to reduce the risk of hyperstimulation is to reduce or to stop stimulation. And people might have heard of the term coasting. And what you would do is continue monitoring, but not, withhold using any type of FSH product. That allows some of those eggs to die, but as you can understand, that also reduces your opportunity in the future. So many of those eggs may not do as well, and many may end up not fertilizing or developing normally. So those are the burdens in terms of trying to manage that.
Great, thank you. And how would someone know if they've got it? Would there be symptoms?
Many times, well, we try to prevent it by basically looking before. So that's the first thing to do, is to try to reduce the risk before. But many times, let's say someone who you wouldn't anticipate having OHSS, they may start having bloating. They may end up having some increased weight gain. They'll end up having abdominal swelling. On ultrasound, you'll see fluid accumulate inside around the ovary, and the ovary gets a lot bigger. And you'll start seeing that before the actual retrieval, but many times OHSS will worsen after the retrieval, and that's something that many patients don't really think about or don't really anticipate. Mm-hmm. So the concern isn't necessarily what happens before. It's a lot of the things that occur afterwards, because that's when you're running into a lot of the complications that may arise.
So might it be a shock for people in that they think that the cycle is done,
right,
if not having a transfer, and then suddenly this happens after the retrieval?
Right. So therefore, typically in a patient who has a lot of eggs, the concern is that you might develop ovarian hyperstimulation, and therefore someone who's looking forward to having an embryo transfer will then be told it's too risky to do an embryo transfer, and therefore we'll end up having to freeze the embryos and not do a transfer. Someone who's not planning to do a transfer, but we're just freezing eggs or just freezing embryos, may then think, well, after the retrieval, they can go back to normal activity. They'll actually reduce their weight pretty quickly. They can start exercising and doing all those things. And then, within 3 and 5 days after the retrieval, if they're not being monitored closely, that's when the symptoms develop. And the symptoms may be, a lot worsening of the abdominal swelling. The ovary gets a lot bigger. It leaks more fluid. Patients may not be able to kind of go to the bathroom to urinate. You'll end up having shortness of breath. So, in earlier situations with patients with ovarian hyperstimulation, you can end up having to be hospitalized to manage that. Fortunately, we're actually more aggressive now in terms of managing it as an outpatient. So we really try to basically do all the measures we can to reduce those things before it occurs. So, hydrating patients with appropriate regimens for increasing the amount of salt within in the intravascular space pulls fluid out. Having them pee more is another way in terms of basically reducing that. But you're trying to manage many of those symptoms well before it occurs. The other thing that has been developed more recently is just that OHSS also is worsened because of some of the medicines we use to trigger egg maturation, typically
Right.
HCG. So, and in patients who get pregnant after the stimulation, they say that the HCG that the pregnancy makes worsens ovarian hyperstimulation because it continues to stimulate the ovaries, it continues to leak fluid, and that worsens things. So one measure that's actually significantly reduced the amount of patients with ovarian hyperstimulation is using Lupron to mature and trigger egg maturation. And we've done a lot in terms of basically managing and figuring out what's the best way. Initially, when we used Lupron to trigger maturation, we ended up having a lot less mature eggs. But now it's actually been pretty firmly worked out that using the trigger markedly reduces the risk of hyperstimulation. And then restarting the the Lupron after the retrieval also further reduces the risk. The other thing that we've done is at the time of the trigger, adding cabergoline, which is an agent, it's an oral medication that you use to kind of suppress what's going on the surface of the ovary. That seems to help quite considerably. So those are the things that we're using now to preemptively manage those patients who may be at risk for ovarian hyperstimulation.
Mm-hmm. So these are the things that Laurel Fertility Care are doing. Is that common practice across clinics?
I'd say that it's becoming more common, and I think that especially when you're looking at patients who are at risk, there's a lot more discussion and a lot more information about that. So I think that is becoming more of a standard in terms of management. Is it ideal? No. There's still some clinics who are still catching up to that regimen, but that's important. But the key thing is just that you want to basically be able to kind of get that and stay on top of things. Mm-hmm. There are some things that you can actually do once you start developing the symptoms to kind of manage and recognize the severity of the hyperstimulation. That means taking some some blood tests to make sure you're not hemoconcentrated, making sure that your electrolytes are well balanced, making sure your kidneys are functioning normally, because those are the things that really in the past severely compromised patients with ovarian hyperstimulation, resulting in the hospitalization, resulting in patients even being at risk for having a lot of problems with that. Right. And the other thing too is that we can much more proactively remove the fluid that's actually accumulating, and that drastically reduces the long-term effects of it, because if a lot more fluid actually gets removed, the patient will end up being able to kind of recover a lot more quickly. Mm-hmm. So managing that post-retrieval period is also an active part of managing patients with ovarian hyperstimulation. Mm-hmm.
For anyone who's just joining or watching this back, we're talking about OHSS, ovarian hyperstimulation. Could you just remind people of the symptoms to watch out for, signs and symptoms, and then let's talk a little bit about treatment if you do get it.
So the big thing in terms of watching about symptoms is just that the most common symptom that a patient will see is just that they'll start having a lot more rapid weight gain. Okay. And it's primarily going to be fluid weight that you're gaining, and that becomes more prominent when you'll end up having water seeping from the surface of the ovary into the abdominal cavity. So the next thing that they may actually start noticing is that you'll end up having an increase in what we call your abdominal girth, your abdominal size. And this, some people will feel that they're pregnant even though they just went through a retrieval, and that actually has to do with the fluid as well.
Which is a really good point, because when you've had a retrieval, I remember mm-hmm. looking like I was about 5 months pregnant, feeling very bloated. So how do you know what's normal bloat and what is a worrying sign?
Well, typically after retrieval with all the weight, because at the time of the retrieval, most times you're going to have some fluid administered intravenously. That's how they administer anesthesia. So you're going to expect to have, say, a 1 to 3, maybe even 5 pound weight gain based on, your size and basically, how much fluid you get and how many eggs are retrieved. The fortunate thing is that in most patients, they'll end up losing that weight over the next 24 to 48 hours. After that time, that's when OHSS starts to rise. then in most patients, you'll expect them to start losing weight, not continue to gain weight. So that's one of the reasons why we have patients start monitoring their weights daily, because that monitor the weight and they're starting to basically gain 1, 2, or 3 pounds a day. That's more worrisome with someone with ovarian hyperstimulation, because even if you're eating significant amounts, it's pretty hard to kind of gain that much weight during that period of time.
Mm-hmm.
The other thing that you'll also note during that time is that you basically have a lot more abdominal girth, distension, or increase in the size of the abdominal girth. And then, that's when you start getting shortness of breath. Some patients, if they're not treated, will end up having, part where they'll end up not being able to sleep at night, or having to sleep propped up on a pillow or sitting, just because the fluid is built up and it's really hard to breathe.
Mm-hmm.
And under rare circumstances, you can have fluid go even into the chest cavity, and those compress the lungs, and that's when it becomes severe.
Mm-hmm.
And then they have to be managed.
And how quickly could these symptoms come on? Could it happen quite quickly?
In patients, it can come on as quickly as in 24 to 48 hours. It's not likely to occur like immediately after the retrieval. And that's one of the reasons why it's pretty critical to basically monitor really carefully within those first 48 to 72 hours, because that's when you want to know exactly what's going on. If someone basically has a retrieval, notes that weight gain, and basically doesn't say anything, then by the time it starts to get to the point where it's significant, it may be either too, it'll be more advanced. And then, especially in certain communities where there's not a way to kind of manage that, that's when they'll end up in the hospital. Mm-hmm. The unfortunate thing is just that going to a specialist to manage ovarian hyperstimulation is one thing, because we actually are well versed in how to manage as an outpatient. That's how it's managed most times. You'll end up having a lot of reports when patients go back to their community, show up in the emergency room of that community, and then end up having significant things done to them that worsens the symptoms of ovarian hyperstimulation. Many of those patients will end up having, fluids, injected intravenously to try to manage those symptoms. That basically worsens the situation, because that fluid then goes and increases the abdominal girth rather than reducing it. And so
what
therefore,
is the treatment plan? What is the adequate treatment plan?
The best plan is preemptive treatment. So therefore, at the time of the retrieval, if you're anticipating that someone's going to have ovarian hyperstimulation, at the time of trigger, using cabergoline as a way to kind of help to reduce the risk of that happening. They're also using, at the time of the retrieval, some measures to kind of reduce the amount of intravascular fluid you're administering. Mm-hmm. So therefore, you're giving enough to basically do the retrieval, administer drugs, but not adding to the burden. After the retrieval, making sure the patient basically moderates their oral intake to stop using free water and start using a lot of fluid, electrolyte-rich fluids, Gatorade, and Propel, and others. Using tea, anything that'll basically act as a diuretic. Monitoring their weight really carefully. If the patient then starts to develop symptoms, seeing them back early so they can kind of monitor and basically manage the symptoms. So, maybe seeing the patient back at 40 to 72 hours after the retrieval. And if there's a lot of fluid that's there, remove the fluid, and it'll be simpler to do it like you're doing a retrieval, but this time you're just removing the fluid, because that allows the kidneys to kind of basically get re-perfused. It allows the patient to then start going through that process to auto-regulate, and that's a significant way to kind of improve the symptoms. Mm-hmm. And doing that at whatever time interval that's necessary, because each patient is different, so you're kind of managing the symptoms. Is
it very painful to have OHSS? Someone was saying earlier that it was a really bad time for them.
It can be pretty painful, because essentially most patients, when they're going through fertility treatment, you're going through with this great expectation that you're going to create a lot of eggs, and that'll be the end of it, and it'll be glory. Your doctor tells you that you'll recover in 48 to 72 hours, and you can go back to your normal life, your normal pattern. Patients with ovarian hyperstimulation may take weeks to a month to kind of fully recover, because once you're behind the part where basically you get too overstimulated, it takes a while for that over to recover, and therefore even with repeated drainage, even with repeated measures, that symptom may continue. So, those patients, rather than actually taking just, 3 to 5 days to kind of fully recover, it may take, 3 weeks before their ovary gets back to normal, where they can fit into their normal clothes, and then, start doing activities again. So those are the biggest things that patients complain about. Again, one of the biggest things is just that if you're used to being a certain size, and then you now feel like you can't fit into your normal clothes, that becomes discomforting for many patients. So those are about.
What happens if you get it after a transfer and you're pregnant?
That's a challenge, and fortunately, we've actually gone through measures where we can find out and see that before the transfer. So therefore, most times what we'll do is basically defer or delay or cancel a transfer. In the past, when we were doing transfers on day 2 or day 3, because basically, and this is truly historical, when the quality of the IVF lab was not as great. Basically, we would end up having a transfer. Patients will end up, and you're transferring multiple pregnancies, multiple embryos. That patient will end up saying, or having twins. That's a lot more HCG stimulating the ovary, and those patients get very sick. Under rare circumstances, you can end up having a situation where a patient is going through with the desire to get pregnant, and then having to make the decision to terminate the pregnancy to manage the risk to her of having severe hyperstimulation. Fortunately, that hasn't happened in quite some time, so therefore that's a really rare occurrence.
Okay, good.
I'd say, that's actually happened in the last 10 or 15 years in the United States, maybe once or twice.
Okay.
Whereas, in the past, back in the 70s and 80s, it was happening pretty frequently, where that would actually be. There were also circumstances where patients would end up having renal failure and renal compromise, and there have been reported deaths from ovarian hyperstimulation just because the symptoms were noted later. Patients got pregnant, didn't want to terminate the pregnancy, and then basically ended up, succumbing to that. So, fortunately, that hasn't occurred in the United States in quite some time. So therefore, that's actually really encouraging. But at the same time, that's something we need to know. We know it's actually a possibility, and that's one of the reasons why we're aggressive in managing that.
Yeah. And what about if you've had OHSS? Should you be worried that it will affect your future fertility outcome?
Fortunately, no. We know there's been a number of studies. The European Society of Reproductive Medicine and also the Australians manage and monitor patients long term. And so we know that basically patients with ovarian hyperstimulation, once they've recovered, go back to their normal life without really any sequelae. And once the ovary goes back down to normal size, everything kind of returns to normal space. Patients who've actually, had the misfortune of, going to someplace where to manage their hyperstimulation, you have a doctor who's not capable of treating that patient, and some patients have lost their ovaries because of it. But those are really, really extreme circumstances where, it was going to a clinic or going to a hospital where they're just not used to managing patients with ovarian hyperstimulation. So if anything else, the first thing I'd say to your group is to make sure that when you're going and you're having symptoms, you're being managed by someone who understands and knows how to manage the disease, because that's the way to best manage the risk of not having surgery that you don't need. The other thing too is just that after you let's say you've gotten pregnant and you've gotten beyond the hyperstimulation. Once the ovarian hyperstimulation resolved, the rest of the pregnancy occurs normally. So not all patients who get pregnant and have developed hyperstimulation will end up having to terminate the pregnancy, but there are them that will actually continue. So those are the things. And then and the last part is that, let's say someone who goes to ovarian hyperstimulation and then has to go through a subsequent cycle, then those patients may be at less risk for that, because you'll do a lot more measures to manage and monitor their symptoms well before, typically using smaller doses of medicine, seeing them more frequently, just so you'll actually not have the same situation occur.
Great. Well, Dr. Smikle, it's been so wonderful to speak with you today, and we appreciate all of your knowledge and expertise, everything that you've just talked us through about OHSS. Please do tap our link in bio, check Laurel Fertility Care out. They'd be more than happy to give you a personalised consult and talk to you about your needs and personalised treatment plans. So thank you once again for all of that wonderfully useful information, and it's great to see you as always.
Well, wonderful seeing you as well, and I hope this was meaningful for your audience, and then, you know, we can go from there.
Absolutely. If anyone has any more questions for the team at Laurel or Dr. Smikle, please DM us, DM them, and either of us will be happy to help you. So thank you very much, Dr. Smikle.
Oh, you're welcome. Take care now.
See you soon.
Bye-bye.
Bye-bye. Thanks, everyone. Bye-bye.